Hi, Ms. Hennigan. My name is Stephanie, and I'm an occupational therapy student. As an occupational therapist, I'm interested in the things that you need to accomplish on a day-to-day basis that might be hard for you to now do due to a recent injury or illness that you might have experienced. Occupational therapists are interested in the things that are important to you as an individual and to help you accomplish those tasks so you can have a meaningful and fulfilling life. So some important things to know as the OT when working with a C5 tetraplegic patient would be that they are off of the ventilator, but their cough and vital capacities are impaired. They would require assistance with upper body dressing and would be completely dependent in their lower extremity tasks. So lower body dressing, bowel and bladder care, bathing, anything like that with the lower extremities. So to teach a C5 tetraplegic patient how to feed themselves with a FEM score of 4 would mean that they are expected to do 75% of the task independently, and then the OT or the therapist would provide 25% of assistance, so minimal assistance. I would first educate them on the different orthosis that they can use, and they could use a universal cuff, wrist hand orthosis, or a balanced forearm orthosis, and all of these would be for stabilization. So with the universal cuff, I would first demonstrate how I wanted them to complete the task. And so I would put the universal cuff on, put the spoon in, and then I would lower it into the bowl. I would scoop up the cereal and then flex my bicep to bring it to my mouth and feed myself. So I would demonstrate that first and ask if they have any questions, and then I would want them to complete it, and then I would provide feedback whenever it was needed. And so I would provide, again, 25% or less assistance throughout all of this. And I would do repeated training sessions and adequate time to maximize the gains that are made with the adaptive equipment and just make sure that they feel comfortable with everything. Oral apraxia is a neurological condition in which it makes it hard for an individual to produce intelligible words or movements with their mouth. And so it makes it hard for them to move their jaws, their lips, or their tongues. And they can do these throughout the day automatically because the muscles are still intact and they are working, but whenever they are given a command to do something, they can't follow through with the task. And so to do this, I would do a simple screening, and I would ask the patient, can you lick your lips for me? So if they are unable to do the automatic command, then I would either get peanut butter or honey to put something on their lips, and I would place it on their lips. And then if they automatically lick it off, that would be like an automatic reflex, and it would show that it is oral apraxia. And if they were unable to lick the honey or peanut butter off their lips, then this would be dysarthria, in which the muscles of the mouth are actually affected. A C6 tetraplegic patient would be independent in feeding, grooming, and upper body dressing after setup by the therapist. They would be dependent in all of the lower body movements like dressing, bowel and bladder care, and bathing. So the goal of a exercise program for a C6 tetraplegic patient would be to move up in the neurological level that they're in. And the muscles that I would want to focus on would be the radial extensor muscles, so the ECRL and the ECRB, and then the serratus anterior for stabilization, to help with transfers, the latissimus dorsi, as well as the triceps to help with those transfers to be as independent as they can. And the intervention plan that I would implement would be a warm-up, and this would just be light stretching or the use of therapy as preparatory activities to get them prepared for the exercise, which would prevent muscle contractures and just make sure their muscles are safe and ready to go for the exercise. So they do have a 3+ grade for their muscles, which means it would have complete range of motion against gravity with a slight resistance. So that being said, for the exercise program, I would use a light resistance band, and I would have them repeat 3 sets of 30-second repetitions 2 to 3 times a week. And it would just be the band parallel to the floor, and then I would instruct them to put it on the outside of their hands, and it'll be on their fingers, and then have them move their wrists outwards. And this movement would strengthen their extensor muscles, and this is parallel to the floor, and the movement is in the transverse plane. And if I wanted to get more involved as the therapist, then I could also provide resistance perpendicular to the floor, and I would have them set their hand like this, put the resistance band this way, provide resistance perpendicular to the floor, and then have them move their wrists up. So go ahead and move it up for me. And this movement would be in the sagittal plane. So after this exercise program, hopefully the muscles strengthen, and then the triceps will hopefully become reinnervated, so it can help with the transfers, and this would most likely happen 6 to 9 months after the injury. A body-powered prosthesis is very practical for patients who might have had an amputation. However, they are heavier than the typical arm, so to prepare them appropriately for this prosthesis, their exercise program needs to be a little bit more intensive, so they don't hurt themselves and their muscles are good and ready to go whenever they get that prosthesis. And the muscles that are needed to control this would be glenohumeral flexion, scapular abduction, shoulder depression and elevation, as well as chest expansion and elbow flexion. So for this example, I'm going to be working on shoulder elevation and depression. So I would instruct the patient. I would use moderate to high resistance bands because, again, it needs to be a little bit more intensive to prepare them for that prosthesis. So I put it on their shoulder. I would provide resistance perpendicular to the ground and then have them shrug their shoulders up and then down, up again, and down. And this movement would be in the frontal plane. Thank you. I would recommend to do this exercise program daily to prepare for that prosthesis and do 3 sets of 12 reps. And start off with the moderate resistance and then move up to the high resistance, or use a therapist or a partner for more resistance. Hi, Miss Betty. My name is Stephanie. How are you today?
Hi, I'm good. How are you?
I'm doing well. So today we're going to be doing passive range of motion. I'm just going to be holding your limbs and I will be moving them in different directions. And so if at any time anything hurts, then let me know and we can stop, okay?
Okay.
So first we'll start with shoulder flexion, and then shoulder extension, okay, then a abduction, a deduction, okay, and then we'll do internal rotation and external rotation. Let me extend up. I'll do elbow flexion and elbow extension. Okay, relax. And then we'll do supination and pronation, and then radial deviation, ulnar deviation, make a fist. Okay, and we are all done. Thank you so much.
Thank you.